Hey there, welcome back. My name is Ashley, and owner of the Happy Martha, and I am a nurse, fertility awareness educator, and a sexual hormone health coach. And my passion is educating others about hormones and teaching you about how to chart your cycles for conception, contraception, and overall health. But today we're going back to my nursing days of when I was a labor and delivery nurse. And the reason I am sharing this with you is because last night I had the opportunity to teach an in-person class we named it the Postpartum Prep Push class. And this is for those who are going to be experiencing postpartum in the near future. And this class was really good. I shared it with two other providers. One was a doula, and the other was a pelvic floor therapist. And we taught a whole bunch of good things, but some things that came up actually were related to what you can actually ask for at the hospital. And being a nurse working at the hospital, I had 15 years of hospital experience. I began my hospital days in ortho trauma. And then I moved into being a hospital supervisor. So I actually helped manage an entire hospital that was actually a very large hospital. And I learned a lot in my time in that space of what you can ask for and what you are allotted um, to be given, and what you can deny in your hospital care and treatment. And so I worked with many patients over the years, and then I became a labor and delivery nurse. And this is where I really advocated for my patients. And I really wanted to give them the best experience that I could give them in a hospital in a hospital place, like a safe place. And I knew I knew all of the ins and outs of what you could not so much refuse, but decline politely. And what was kind of like a maybe just a hospital policy or a hospital protocol that there was a way around. And so I'm going to kind of share some things that I learned of being a labor and delivery nurse over 8 years. And this is kind of what came up last night too. And so I'm going to share those with you. And the first thing that came up was choosing who you want to take care of you. And this is a big one. So if you are pregnant and you have your doctor that you see or your midwife that you see, and you're going to be delivering at a hospital, the biggest thing that I think you can do is kind of know and go in having an open mind, knowing that there's going to be multiple people caring for you at the hospital. Now, this is, you're going to see probably lab people, phlebotomists. You're going to run into different nurses, in triage, and then possibly in labor and delivery, and then possibly again in postpartum, depending on how big the hospital is, and if you do move to a postpartum floor. You're also going to have different doctors. So I think the first thing is knowing that your healthcare provider or your doctor or your midwife might not be on call that day when you decide to go into labor, and having that open and understanding what is going on, and understanding where your providers are, and that all providers practice differently, and that you choose a um, provider or a doctor's office that has like-minded providers. I think that is going to help you so that you aren't thrown off if you end up in the hospital and you don't have the provider that you really wanted. And this provider is just not meeting your needs. So the first thing is one, you can ask for a different provider or see who is on call for the next 12 to 24 hours. Um, all call is different for doctors, and so you kind of got to, see. Some doctors will come in specially, but don't think that you're their special patient. And I don't mean that to be mean. Doctors have lives, midwives have lives outside of the hospital and outside of delivery. And so when they're off, they're off. And of course, when they're on, they're on, and they're there to support you. But they might not come in unless they're, a really good, close friend of yours or something like that. They might just not just come in for you. And so you're going to really have to kind of understand that when you choose a provider, that's going to kind of be the office is going to be who you're choosing more so than just one specific provider. The next thing is you can ask, like, let's say you want to have a very natural delivery, a very physiological birth, where it's very hands off. And you are staying at home, you're laboring, you might have a doula, you might have a good support system, but you also want kind of a naturally minded nurse or a nurse that's going to be able to support you through this labor as well. Did you know that you can actually ask, hey, do you have any nurses that are kind of naturally minded or don't mind the natural gig of, of delivery and labor? And so you can ask to see if there are nurses available that really like that physiological birth, that really like that natural birth, that are there to support you in any labor position, that are going to work with you on, movement and monitoring and things like that. So that was the first thing that we actually talked about in our prep class last night. And everyone that was there could not believe that you could ask for this. And so this is something that is totally, and I will tell you that the nurses know who are natural, and the nurses know if, they like being in the OR or they like a hands-off approach. And usually the hands-off approach will be like it's not that they're not going to be nurturing or caring for you in a bad way. They are just going to let you do your thing, and they aren't going to be in there, doing hip squeezes and, doing all that. And they might even be pushing epidural on you or something like that. So, you need to be clear in what you say. As far as a birth plan goes, this is kind of a little side note. So you can say all you want in your birth plan, right? But it's really in that moment, you need to give the desire of what you want and what you need in that moment and have a face-to-face conversation versus just handing someone a sheet of paper, okay? Because that paper is going to get lost in your chart. People might scan it and look at it and be like, oh, okay, whatever. Like it's the same old, right? But you really want to have these open conversations. And if a nurse or a healthcare provider is not meeting your needs, or it's just not clicking, you can ask to speak to, the supervisor or the charge nurse on in charge for that day, and you can have them come in and just say, hey, listen, I'm not vibing with this person right now. Is there another person that we could switch out? Because I'm just our values and our alignments are not lining up. So that was number one. You can ask for providers, especially nurses, and if you don't like or don't get along, or it's just a conflict of interest, you can ask for a different nurse or ask for a different care provider. The next thing is you can refuse residents. Um, Most hospitals are learning hospitals. Yes, I realize residents have to get their patient load in. But what I also know is that they have plenty of clients that they can work on. And if you don't want to be one of them, you don't have to be. So you can decline all residents. Now, they're going to be pushy, and the doctors aren't going to like it because they're going to have to come in more and call and check on you more. And so, they're, you're going to have to advocate for this, and that's okay. You can do it. Maybe that's why you hire a doula to help you with this advocation. Maybe it's, you're talking to your significant other and you're like, no, I truly do not want any student or resident in my room helping. I just want my provider and nurse. And that is all you truly need. You really just need two nurses and a provider to deliver a baby, unless there are other circumstances that happen, which in that case, sometimes it's all hands on deck, and that can happen. But in most cases, that's not how it goes. So the next thing is you can ask to move. You can get up and move. Most hospitals nowadays have wireless monitors if you need to be monitored. If you are an uncomplicated, low risk pregnancy, low risk delivery, you don't have to be monitored 24/7. And it's called intermittent monitoring. You can be intermittent monitored up until you deliver your baby. And every hospital is different based on what their classification of intermittent monitoring is. The place I worked, we would listen before, during, and after a contraction in early labor. As labor picked up, we would listen for about 20 minutes. We'd put you on the monitor every hour, and then we would take you off. Once you started pushing, we would listen about every 20 to 30 minutes. And then actively delivering was it varied really, but 5 to 10 minutes, depending on, and we would just listen to make sure the heartbeat was still good and sounding well. So you can ask for that. Other things you can ask for are peanut balls, for squatting bars, for sheets, extra warm blankets, extra pillows, although pillows are hard to come by sometimes in the labor and delivery unit. I highly recommend bringing snacks. Some hospitals are now allowing mothers to eat during labor. There is a lot of back and forth between anesthesia and labor and delivery, because the risk of eating during labor is that you could potentially aspirate what you eat if you should need an emergency C-section and have to be intubated. This was always a fight for my patients, and to be honest with you, I never restricted my patients. If they wanted to eat a granola bar, I allowed them to eat a granola bar, or I just walked out of the room and said, "You do you," because I feel as though this risk is extremely low. There's not a whole lot of evidence-based uh, practice based off of this, off of restricting. And if you were to go eat a large meal and get in an accident and need to be intubated, they would do it. And yes, you would be at risk for aspiration. So I think as long as you are understanding that should a huge emergency happen, you are at a higher risk if you have a really full belly for aspirating. But when we're in labor, we don't really like to eat a lot. We might just need like a little pick me up, a little snack. Maybe some, jerky or some, honey with tea or some soup. Those types of things are really light. I guess maybe jerky isn't very light, but I liked jerky when I was in labor. But maybe a granola bar or something like that, or some fruit, vegetables, things like that. Um, it's light and you're just going to want to nibble and snack anyway. It's not like you're going to want a full, three-course meal. And so it's going to be easily digested, and your risk is going to be lower. So bring the snacks. That was my big thing. And whoever is in the room with you, they want snacks too. So plan ahead, okay? Next is you can push. Well, let's not do pushing just yet. Let's talk about Pitocin and IVs. So IVs, you can, if you are, once again, if you are low risk, there is no reason why you should need any medication or anything like that. You truly don't need an IV, and you can decline an IV. They will try to push a saline lock is what it's called, where they put the needle in the IV catheter, and then they'll take the needle out, but the IV catheter stays in under the skin in your vein, and then they'll tape it down. And if you should want pain medication or want an epidural or there is an emergency that happens, that IV is already established and in there. And so we don't have to worry about getting one in frantically when, shit hits the fan, like as I like to say, because sometimes it hits the fan. And being prepared is the job of the hospital and the job of the nurse and the job of the doctor. And so we want to be prepared. But that you don't have to have it. You can politely decline. Um, we are very competent at our jobs. We are very good at getting IVs in. Most of us are. And most of the time we don't have problems. So if something arises where you need an IV, we're going to get one in you. It's not a big deal. And, we might actually put one or two in you, and that's kind of how it goes. So saying no to that initially is totally fine. And down the road, if you should want some more interventions, then by all means, ask for them, which kind of leads us into my next thing, which is um, pain medication. Okay. I highly, highly recommend you do some form of birthing education. Okay, that could look like, um, taking a birthing class, a hypnobirth, yoga, meditation, reading some books on birth, and just knowing the physiological signs of labor and what your body is going through. I cannot recommend that enough. And but sometimes we need some help and we get tired and or our desire is to have a pain-free birth with medication. And so I highly recommend you look up what hospital you will be delivering at and what their options are for pain management during labor. Now, at the hospital I worked with, we had a bunch of different ways to manage pain. Um, we had nitrous oxide, which is like laughing gas, where you inhale and you put it over, it's a mask or I think they have like breathing tubes now that you can like kind of breathe in, almost like a nebulizer. And you're breathing in the nitric oxide, the gas, the laughing gas, and it kind of just dulls the pain a little bit. It kind of puts you in this dreamlike state. Um, and you can use it with each contraction all the way up until delivery occurs. So, and even afterwards, you can use it afterwards for pain management as well. So like your labor pains, delivering of the placenta, things like that. Now we had a separate unit. So we had labor and delivery, and then we had a postpartum unit. And so when people went up to postpartum, I don't believe they had access to the gas. But there are other things too. So other medications, Stadol is an IV medication. So that would mean that you would need to have an IV present. And this medication goes through into your vein. It can affect the baby, and it makes you feel kind of like you've had a few glasses of wine. And so this medication is safe for baby, but it can cause it's an intervention. And so it can cause issues with the baby to be kind of sleepy, heart rate drops or can dip. And so, and this can only be used 3 times. So you can get 3 shots and then you're done. And the reason why is because it kind of builds on itself, and you are like, once you hit the max limit of your 3, you're not really going to get any more pain relief from it. Now, if you're using it, like let's say you used it once and then 12 hours later, you're using it again, totally fine. You're still going to get the same results. But if you're using it every hour for 3 hours in a row, and then you're like, I want one more for my fourth hour, that fourth hour, you might not feel the effects very much because your saturation limits of the medication are just not going to be as strong just with this particular medication. The next is if you have back labor, I think the best pain management is movement or a tub or a shower. I also think that if that you have a provider that is well versed in doing water pustules in the back. So basically, what we do is we insert saline water into these little like round pustules, and there's different areas that you can do in the lower back for back labor. And it goes into the subcutaneous tissue and then it disperses. And that has been really helpful for some people who experience back labor and pain in the lower back. There is also um, a, let's see, what else was there? I lost my train of thought. Sorry, guys. Obviously, you can get an epidural. And especially if you're a first-time mom, getting an epidural is you can get it up until you're pushing, so long as you can hold still for the anesthesiologist. And by hold still, I mean sitting on the edge of the bed, holding a pillow and curled over like a madcap. So if you can be in that position for a good 15 minutes, typically that anesthesiologist will do it no problem. Now, if you're thrashing and are so uncomfortable and you cannot get in that position, um, you know, the nurses and the anesthesiologists are going to try really hard to put that epidural in, but they have to get it in such a small space and really do it right in order to get you what you need. So I think it's just really you have to know where your limit is and know, okay, am I too far gone? I really wanted to do this natural. Can I get through it? How can I get through it? What are some coping mechanisms that I can go back to? Um, pudendal block. That's what I was going to talk about. So, some doctors are well versed in these. They're called pudendal blocks. And what they do is they insert lidocaine into the pudendum nerve, and it is with a needle, and it is down by your lady bits, and you can Google where the pudendal nerve is. But what this can do is it can help with that ring of fire, that burning. But please note that not every provider is well versed in this. And actually, when I worked labor and delivery, there was always one provider that always offered it to her client, her patients, and her patients loved them. So I think that it's good to talk with your doctor about these options prior to the delivery, as well, because the doctor is going to be ordering these. So if you don't talk to your doctor about what you want or what you might want, then you're not going to have these on your standing lab orders, or your standing orders for admission into the hospital. So, kind of having these conversations, like I kind of want the availability to use the gas. Can you make sure that's, on my orders when I get admitted? Or, when you go into triage, just say, this is what I really am looking forward to. Can you please order that? Even an epidural needs to be ordered by a physician. And typically it's standard and usually clicked by a physician, but not all the time. So these are things that you need to have conversations about. Um, Next, let's talk about Pitocin. Oh, Pitocin. There's a lot. There's a lot to talk about. This could be a whole nother episode, honestly, on just Pitocin, but I'm going to just briefly touch on what Pitocin is and why it's used in the medical setting. So, Pitocin is the synthetic form of oxytocin. Oxytocin is our love hormone. It is the hormone in which milk is released from our breast if we are lactating. And it is also kind of that hormone that um, triggers our contractions to start. So when we have our natural oxytocin running through our body when we go into labor, our uterus will contract and it will give us our contractions. However, sometimes, um, and Pitocin also clamps down the uterus after we have our baby, which helps prevent bleeding from occurring or hemorrhaging from happening. And while the drug Pitocin has saved millions of lives, it also has been used in a way that it's been like a treat-all, kind of like what birth control is, right? Oh, you have this, here, we'll give you some birth control. In the postpartum or in the labor and delivery world, Pitocin is that drug. Okay. Oh, you aren't contracting? Let's give you some Pitocin. Oh, you're hemorrhaging? Let's give you some Pitocin. It's kind of the thing. Oh, you haven't delivered your placenta yet. Let's give you some Pitocin. Postpartum Pitocin was actually started and is used to prevent hemorrhages. However, if you're not at risk for a hemorrhage, you don't necessarily need it. And Pitocin can also really disrupt that mother-baby bond. It can disrupt milk letdown and your milk coming in. And so it's really important to really weigh the benefits and risks of Pitocin, and I highly recommend you look into that. You can always reach out to me if you want more information. There's a bunch of good literature out there. Um, Regarding Pitocin. So you can refuse postpartum Pitocin, which is kind of what we talked about last night too, is we talked about how, Pitocin is given after every delivery. So after you deliver a baby, the thing to come out it next would be your placenta. And usually, either right before placenta is getting ready to detach from the uterine wall or right after it detaches and comes out and is delivered, IV Pitocin is given no matter what, unless you decline it, which you can. And there are other medications that you can get if you should be hemorrhaging or start to have a little bit more bleeding than what the doctor likes. You or your uterus isn't clamping down. or you're at risk, like maybe you have a bleeding disorder, right? So there are other medications that you can get other than IV Pitocin, but just know that Pitocin is the standard drug for that. But you can decline it. So just know that. It might be a hospital policy, but you can decline hospital policies. Um, okay, so let's talk about delayed cord clamping and stimulating your own baby. So this actually didn't come up last night, but I thought about it. As I was like laying in bed, I was like, oh man, I should have covered this too. So I want to cover it with you guys too. So delayed cord clamping did come up. So delayed cord clamping actually is so it's where the cord to the placenta and the baby are hooked up. And what we do is once the baby is born, the um, cord will pulsate the blood back into the baby. And this helps the baby to get all of the blood, all of the nutrients that is coming from the placenta. Now, at least 1 minute should be given to delay the cord clamp. However, if you really want to get the full benefits, you should request, and this is how you would say it, that you want to wait to cut the cord, or your spouse or whoever's cutting the cord, you want to wait until the cord stops pulsating. Okay, you have to say it. You can't just say delayed cord clamping because they're going to probably just do 1 minute and cut it, and maybe not all that blood is going to be in there. You literally want the cord to be white and limp. You can look down, you can look at your cord, you can look at the baby, and you can see, okay, this is what I want. Now, the only reason that they would cut or they would clamp and cut the cord quickly before that is if you had a traumatic delivery, if the baby isn't doing well, maybe not breathing, is limp. There are things called APGARs that us as nurses actually do. And we take like a list, like is the baby blue? Is it pink? Is it acrocyanotic? Is the baby breathing? Is it not breathing? And we go down this list that as nurses we have just in our head of what does a good baby look like and what does a not so doing good baby look like, okay? And we determine this, and we actually determine, okay, we need to cut the cord, even though it might still be pulsating, because we need to give the baby some resuscitation. And this could be because it was, like I said, a traumatic delivery. Maybe the baby was having low heart tones. Maybe, sometimes if you're on antidepressants like an SSRI, it can make the baby really sleepy and not want to breathe. And so these are all things that we would potentially want to assess the baby further and have a standby of other nurses to be able to help resuscitate the baby should we need it. This is very rare. We don't resuscitate babies a lot, but it does happen. And depending on how many babies your hospital is having, the hospital I worked with, we had a very large unit. And so we resuscitated a lot of babies because we had a lot of babies coming through it. But it's not always the norm. So I don't want it to freak you out and make you think that, this is the standard of care. It's not. So delayed cord clamping, going back to that, just make sure that if you have an uneventful labor and delivery, you can delay this cord clamping and you can wipe your baby off. You can stimulate your baby. The nurses don't have to be rough, and you can state that. I actually delivered a family member not that long ago, and I was appalled. I was there not as a nurse. I was there as her doula and her support person. And I was appalled at how rough the nurses were stimulating this baby. And I even have it on video. And I look back sometimes to that video and I'm just appalled at how rough they were. And it turns out the baby had a broken clavicle on top of it. And so it makes you wonder, was that delivery, was it caused from the trauma of the nurses stimulating? So just know that you can bring your baby up to your chest. You can stimulate your own baby. You can wipe it off. You can clear it. It doesn't have to be rushed. It can be peaceful, but you have to be very, very clear about what you want in that delivery. Okay. You have to be clear with your nurses. And every time a new nurse comes on, you have to say it again because it might not come up in report. Okay. You have to be clear with your doctors. If you get a new doctor throughout your transition or your stay at the hospital, you have to be clear. This is what I want, and you need to state it. And I promise you, if you are clear and concise in what you want, they are most likely going to give you what you want. Not always, but I will say that if you can have this good open communication with them, it will work out in your benefit. Okay, finally, and then I think we're going to be done with this one. If you guys want to hear more about this kind of thing, please leave a comment. I'd love to know like what you want to hear more of. And I love teaching about the postpartum phase, but you guys, I love birth and delivery. It's in my blood. I've always loved it, and I think being a labor and delivery nurse both in the hospital and doing home births because I did 2 years of being a birth assistant with a couple midwives. And that really changed my perspective of what labor and delivery can look like. And so there's two different ways. And yes, some are needed, but I absolutely love talking about this. So if you want to hear more about it, just let me know. Last thing, and then we're going to be done, is have people surrounding you that you want there. Okay. Just because your mom wants to be there doesn't mean she has to be. All right. Just because, your dad, you didn't call your dad and, um, he's mad because you didn't tell him that you were in labor, that's okay. Or, your sister really wanted to be there and now she's mad at you. But you didn't feel safe with your sister or whoever being there, okay? Have who you feel safe with at the hospital. And maybe that's hired help. Maybe that is a doula. Maybe it's, your friend who has had a baby before and you really trust her to take care of you. Maybe it's your spouse, or maybe your spouse or significant other is like, this is not my jam. I need some support. Bring that in because I want you to feel that safety. And also, I want you to know that your nurse, while she'll be able to help you in some aspects, especially if she's more into the natural thing and the natural route of physiological birth, she also has a job to do, and she is going to be charting and monitoring you, monitoring the baby, making phone calls with doctors and physicians, making sure things are clear. She might be helping with other deliveries. And so don't rely on nursing staff to be able to help you cope through labor because not everyone can do that. And so, and not everyone will do that. They might not qualify that as their job. Okay. Even though I loved supporting moms and I literally would camp out in rooms all day long, and chart within the room and support you and love you and, do all the things. That's not everyone. And so hiring that extra person that knows something, I think can be really helpful. Um, I 100% loved working with doulas as a nurse, but that's not always the case. And I think having if you do hire a doula, introducing that doula to your nurse, introducing that doula to your provider, and being like, this is my care team. This is who I want to be here for me and to care for me. And, I feel safe in this area because your body is going to be able to have a very uncomplicated labor and delivery when it is safe. It's no different from, like ovulation and all the other hormonal aspects that I teach, right? Like this is your body is wanting to, if it's safe and it feels nurtured and cared for and relaxed, it's going to know what to do. Okay. So, all right, I'm going to end there. Please let me know your thoughts on this and chime in if you're a labor and delivery nurse, chime in. I'd love to hear your thoughts and perspectives. I know I take kind of an alternative approach to nursing, and that's primarily why I no longer do hospital nursing. But I wanted to just kind of give you kind of a roundabout way of what things can look like in the hospital and what you can ask for, because you guys, it's really we want to advocate for you. We want to give you what you need. It's not just a good guy, bad guy thing. It is, you know more and more hospitals are working on putting patient care first. And so that is, I think, a good thing, but also just know that it is an establishment. So, all right, that's it. Thank you so much for being here, and I will talk with you soon.